Hello, everyone. This presentation is just going through the Surviving Sepsis Campaign, the guidelines on the management of critically ill adults with coronavirus disease. This entire presentation comes from the published guidelines from the Surviving Sepsis Campaign. Here's a list of the authors that made this guideline. So these guidelines for the treatment of COVID-19 in critically ill adults was created by a panel of 36 experts from 12 countries. They asked 53 questions relevant to the management of COVID-19 in the ICU and made their recommendations based on the GRADE approach. WHO and the United States Center for Disease Control and Prevention have issued preliminary guidance on infection control, screening, and the diagnosis in the general population only. There is limited guidance currently on the acute management of critically ill patients, and that's why these guidelines were created. They basically broke down their guidelines into about 4 or 5 different categories. They did infection control, and then they did laboratory and diagnosis, and then also specimens, hemodynamic support, ventilator support, and then therapy. So first we're going to go through the infection control recommendations. So for healthcare workers performing aerosol-generating procedures on patients with COVID-19 in the ICU, which these include endotracheal intubation, bronchoscopy, open suctioning, administration of a nebulized treatment, manual ventilation before intubation, physical proning of the patient, disconnecting the ventilator from the patient, non-invasive positive pressure ventilation, tracheostomy, and cardiopulmonary resuscitation, it is recommended to use fitted respiratory masks. These are the N95 respirators or their equivalent, as opposed to just regular surgical or medical masks. In addition, we're supposed to be wearing personal protective equipment, which includes gowns, gloves, and eye protection. It is important to note that bronchoscopies are among the procedures at highest risk for aerosolization. And per these guidelines, they recommend us not even performing bronchoscopies, or at least only performing them at the minimum level possible. The recommendation for using N95 masks when performing aerosol-generating procedures comes from the concern for high rates of transmission between patients and their healthcare providers. When these guidelines were written, they noted in China over 44,000 laboratory confirmed positive people, they were all healthcare workers. So 3.8% of the positive cases were healthcare workers. In Italy, as of March 15, 2020, there were over 2,000 documented COVID cases among healthcare workers. Respirator masks are designed to block 95 to 99% of aerosolized particles as compared to surgical masks, which are only designed to block large particles, droplets, and sprays. The N95 masks are the ones we are fitted for yearly. When providing usual care for non-ventilated COVID-19 patients or aerosolized generating or non-aerosolized generating procedures on mechanically ventilated patients using surgical or medical masks as opposed to respiratory masks, in addition to other personal protective equipment, is recommended. These recommendations are in line with the World Health Organization and with the current evidence, which suggests that surgical or medical masks are probably non-inferior to N95 respirators for providing protection against laboratory-confirmed seasonal respiratory viral infections, such as influenza. There was only one randomized control trial reported on coronavirus, which tested for seasonal coronavirus by means of PCR in nurses who wore medical masks versus the N95 respirators. They found that 4.3% of nurses in the medical mask group had PCR confirmed coronavirus infection, as compared with 5.7 in the N95 respirator group. From this, they conclude for the regular coronavirus influenza, it doesn't matter whether or not you wear the N95 or the regular medical mask. It is important to note, though, when they are making these recommendations, the panel considered the lack of convincing evidence that the N95 respirators improve clinical outcomes, but they also took in consideration the costs and the resources associated with the N95 mask use and the need to preserve the N95 masks for aerosolized generating procedures. Therefore, the panel issued a suggestion to use medical masks in this context. However, they did note that the SARS-CoV-2 virus does appear to be more easily transmissible and lethal than the seasonal influenza, and that when scarcity is not an issue, use of a fitted respiratory mask is a reasonable option. It is also recommended when performing aerosolized generating procedures in the ICU with patients with COVID-19 that you use a negative pressure room, and this is just to prevent spread throughout the hospital of the virus. It is suggested that for endotracheal intubation, that we perform this using a video-guided laryngoscopy over direct laryngoscopy. They also recommended that the most experienced person with airway management also performs the intubation. And this again is to limit risk to the healthcare providers and the patient, where hopefully we get the airway on the first attempt and minimize any kind of contact between the healthcare team and the patient. So now we'll move into laboratory diagnosis and specimens. The COVID-19 diagnosis is based on reverse transcriptase PCR. And this basically is used by testing respiratory samples from the nasopharynx, the oropharynx, and the lower respiratory tract. Despite the high sensitivity and specificity of the PCR-based analysis, testing performed from oropharyngeal swabs have been demonstrated to have a low negative predictive value. In a recent study, only 9 out of 19 oropharyngeal swabs from COVID-19 patients tested positive by RT-PCR. Another study using seroconversion as the gold standard for the SARS diagnosis, RT-PCR assays performed on nasopharyngeal and throat specimens were positive only 65 and 70% of the time. Consequently, a single negative swab from the upper airway does not rule out the SARS-CoV-2 virus. And repeated samples from multiple sites, including the lower airway, will increase your diagnostic yield. Lower respiratory tract specimens are considered to give a higher diagnostic yield than upper respiratory specimens in patients with the COVID virus, and therefore should be obtained whenever possible. However, again, it is recommended that we do not perform bronchoscopies in these patients and that we obtain the specimen via a tracheal aspirate. Of note, it is also important that to note that patients that are diagnosed with pneumonia can also have the underlying COVID disease. So even in patients that we're already treating for pneumonias, you should also have suspicion for COVID as well. Okay, now we'll go into the guidelines of hemodynamic support. So no direct evidence exists on patients with COVID-19 and shock. Therefore, the panel used indirect evidence from critically ill patients with sepsis and ARDS to inform these recommendations and the recommendations to follow. So these recommendations are pretty consistent with how we manage all of our shock or septic shock patients, as well as our patients with ARDS. So this recommendation is recommending that we use overall a conservative over a liberal fluid strategy to treat the patients with ARDS. The next recommendation is to use crystalloids over using buffered and to use buffered and balanced crystalloids over unbalanced crystalloids. And these would be using things like lactated ringers over normal saline. And they just stated that this is because of it being more like the lactated ringers or the balanced crystalloids being more like the patient's plasma, which is pretty consistent, again, for how we currently treat our patients. And they also are recommending crystalloids over colloids, which again is in line with our normal treatment regimens. There is no direct evidence, again, for COVID-19 patients in shock, and these are based on our recommendations for critically ill patients in general, but they do suggest, again, using Levophed as the first-line vasoactive agent. And then also noted if Levophed is not available, they suggest using either vasopressin or epinephrine as the first-line agent. For adults with COVID-19 in shock, they recommend against using dopamine. And this is due to the concern that there's an increased risk of arrhythmia found in a dopamine arm of a previous study that compared Levophed and norepinephrine in septic shock. Another recommendation is for to add vasopressin as a second-line agent over titrating up the Levophed dose if the mean arterial pressure cannot be achieved by a lower dose of Levophed alone. And they are recommending that we titrate our vasoactive agents to a MAP of 60 to 65, which again, it is in line to our Surviving Sepsis guidelines. They have noted that possibly due to the inflammation caused by COVID, that they've noticed some myositis, cardiac myositis, and elevated troponins in some of these patients and possible overall cardiac dysfunction. So they did add in that with patients with shock, COVID-19, and evidence of cardiac dysfunction and persistent hypoperfusion despite fluid resuscitation, Levophed, and possibly at this point vasopressin, that they suggest adding dobutamine over just increasing the Levophed dose. And this is based on, again, they're finding that possibly some of these patients do have some cardiac dysfunction. For adults with COVID-19 and refractory shock, they do suggest using low-dose corticosteroid over no corticosteroid therapy. And again, the usual dose for this is 200 milligrams per day, administered as either an infusion or as intermittent dosing. Now moving on to ventilator support. So although the true incidence of hypoxic respiratory failure in patients with COVID-19 is not clear, it has been reported that up to 19% of patients develop hypoxic respiratory failure. Recent reports from China showed that 4% to 13% of COVID-19 patients received non-invasive positive pressure ventilation, and that 2.3 to 12% did eventually require invasive ventilation. So in patients with COVID-19, they do suggest that we start supplemental oxygen if the peripheral oxygen saturation is less than 92%. And then also, once you do have a patient on oxygen therapy, they are recommending that we maintain the SpO2 no higher than 96%. And these considerations or these suggestions are due to the concern that oxygen can, at higher levels, cause damage to the lung tissue itself and the free radicals. But then also, they're also concerned about the limiting our resources as oxygen demand goes up. We may not have enough oxygen for everybody. For adults that are in hypoxic respiratory failure despite conventional oxygen therapy, they do suggest using high-flow nasal cannula. High-flow nasal cannula they found does not seem to confer an increased risk of transmission of the disease, and therefore is suggested over using a non-invasive positive pressure ventilation like a BiPAP machine. There is concern for increased risk of viral spread if a patient is on non-invasive positive pressure ventilation. And that is not to say that non-invasive positive pressure ventilation is not beneficial in other critically ill patients, such as patients with CHF, but this is the recommendation in regards to this specific pandemic. They're also recommending early intubation under controlled settings if we feel that a patient is starting to go down that route. Just from reports, it seems like these patients do become hypoxic pretty quickly and decompensate very quickly. So in order to have everything under a controlled setting, allow the treating team to have all their personal protective gear on, they're just saying, intubate even like once you start to think about it, basically, for these patients. This is a nice graph that they include in their guideline publication. It basically goes down a kind of a treating pattern for whether or not you go down the road of endotracheal intubation versus supplemental oxygen, kind of the goals of what parameters you should follow for the oxygen. In mechanically ventilated adults with COVID-19 and ARDS, they're recommending the low tidal volume ventilation and higher tidal volumes and targeting plateau pressures of less than 30 centimeters of water. And these are in line with our current guidelines for treatment of acute respiratory distress syndrome. For mechanically ventilated adults with COVID-19 and moderate to severe ARDS, they are suggesting using a higher PEEP strategy over a lower PEEP strategy. And this is to help recruit the alveoli and hope to ventilate as much healthy lung as possible. Again, they suggest using a conservative fluid strategy over a liberal fluid strategy for the COVID-19 patients in acute respiratory distress syndrome. For mechanically ventilated adults with moderate to severe ARDS, they do suggest prone ventilation for 12 to 16 hours over no prone ventilation. So two adjunctive strategies that they mentioned in these guidelines are the prone positioning and the therapeutic neuromuscular blocking, which we will discuss in the next slide. The theory behind proning positioning is improving ventilation perfusion mismatching and thereby improving gas exchange. Prone positioning has been previously demonstrated to have a mortality benefit in patients with ARDS. This was demonstrated in the 2013 study by Guerin et al. In their multi-center randomized trial, Perseva, where patients with ARDS were prone for 16 hours followed by 8 hours supine. They found a 16.8% reduction in mortality. There are risks involved, however, including increased risk of pressure sores and endotracheal tube obstruction. Healthcare workers proning patients with COVID-19 and in general need to be trained in proper technique for proning and take infection control precautions in the event of an accidental endotracheal tube disconnection from the ventilator. Currently, for mechanically ventilated adults with COVID-19 and moderate to severe ARDS, it is suggested to follow these guidelines. So currently we are actually working on a guidelines about transitioning the patient to the prone position at ECMC in case this is needed. Again, discussing more about the neuromuscular blockade, it could be that second adjunctive strategy for treating ARDS. The theory behind this is to hopefully decrease ventilator-induced lung injury as seen in ARDS and possibly stop the overdistension of relatively healthy lung tissue and then improve overall pulmonary compliance. This is pretty controversial even in the normal septic shock ARDS patient. But right now they are suggesting that we consider using either intermittent bolusing or continuous infusions if we notice significant ventilator dysynchrony and the patient is hypoxic and not responding to other forms of rescue. They are recommending against the use of inhaled nitric oxide, but they are suggesting that we maybe try a trial of inhaled pulmonary vasodilators only as rescue therapy. So in general, right ventricular dysfunction and even right heart failure can be seen in ARDS due to the hypoxic pulmonary vasoconstriction. The most commonly used pulmonary arterial dilator in critical care medicine is inhaled nitric oxide, which has a rapid vasodilatory effect on pulmonary arterioles and capillaries. To date, no studies have shown a survival benefit with this therapy. It has been shown to possibly decrease hypoxemia, but with no change in mortality, likely due to the fact that patients with ARDS do not often die from hypoxemia itself, but from the multi-system organ failure associated. There are no studies that describe the use of pulmonary vasodilators in COVID-19 patients. So again, they're just using the previous data. And there was some note of pulmonary vasodilators being used and shown to improve oxygenation as rescue therapy, and that's why they're suggesting that if we need it, we can trial it. For mechanically ventilated adults, again, with hypoxemia and COVID, they recommend that we do recruitment maneuvers, and they recommend doing basically the ones where you hold for 30 for 30 or 40 for 40 instead of the incremental peak titrations. They found more benefit with the 30 for 30, 40 for 40 recruitment maneuver than the staircase recruitment maneuvers. And then due to the resource intensive nature of ECMO and the need for experienced centers and healthcare workers, ECMO should only be considered in carefully selected patients with COVID-19 and ARDS. Here's another graph that they provided in their publication. It kind of goes through different treatment regimens for mild, moderate, and then rescue therapy. So you can kind of just follow along and treat accordingly. So lastly, we'll go through therapy. So a published but not peer-reviewed report of 26 patients with severe COVID-19 reports that use of methylprednisone at 1 to 2 milligrams per kilogram per day for 5 to 7 days was associated with a shorter duration of supplemental oxygen use. There are several randomized controlled trials on the use of systemic corticosteroids in hospitalized patients with community-acquired pneumonia, mostly non-ICU patients, and some with sepsis or septic shock. A systematic review and a meta-analysis of randomized controlled trials showed that using corticosteroids may reduce the need for mechanical ventilation, ARDS, and the duration of hospitalization, but increase the risk of hyperglycemia requiring treatment. However, these trials included different populations, the effect on mortality outcome was unclear, and they used different drugs and dosing regimens. In addition, there are some concerns about corticosteroid use in viral pneumonias. Therefore, the results may not be generalizable to the COVID-19 population. With the current data available, it is suggested to use systemic corticosteroids in mechanically ventilated adults with COVID-19 and ARDS, and suggest against using it in respiratory failure without ARDS. Due to the high risk of these patients having both an underlying pneumonia as well as the COVID viral pneumonia, they do recommend or suggest using empiric antimicrobials due to this increased risk. And then for critically ill patients who are febrile with COVID, they do suggest using Tylenol for temperature control. And they basically cited that this would help with comfort for the patient and possibly keep them more calm. And then also they noted the concern for using ibuprofen in this patient population due to concern of how it may affect the cytokines and then the inflammatory reaction from the virus itself. They are suggesting against the routine use of standard IVIG. So in the absence of adequate titers of neutralizing antibodies, standard intravenous immunoglobulin is unlikely to have a biologic effect in COVID-19. While IVIG may have some immunomodulatory actions, its use can rarely be associated with an increased risk of serious adverse events such as anaphylaxis. So again, these guidelines are suggesting against the routine use of IVIG. They are suggesting right now against the routine use of convalescent plasma. Now this is basically injecting plasma from patients that have already, recovered from the COVID illness into patients into other people that haven't yet experienced COVID to hopefully provide some passive immunity. They have experimented with this in the previous SARS pandemic and with H1N1. But right now it's unclear exactly how much antibody titers you need to even allow for the patient to have a passive immunity to the virus. So right now they're still current studies going on to see if we can use this, but as of now, they're suggesting against the use of routine use of convalescent plasma. Right now, they're also suggesting against the routine use of lopinavir or ritonavir. And then they're also saying there's insufficient evidence right now for other antiviral agents. And currently, the World Health Organization and a lot of other institutions are working to figure out which antiviral agent, if there are any, could be effective. But right now, there is not enough data to support using any. They're also saying that there is insufficient evidence to issue a recommendation on the use of recombinant interferons. And the hope behind interferon is to kind of prevent the inflammatory changes that occur with this virus that leads to the multi-system organ failure and ARDS. And currently unpublished data, I guess, indicates that interferon beta inhibits the COVID virus in cell culture. And this has actually been prioritized for study by the World Health Organization, but there isn't enough data right now or any evidence to support this routine use. And then still there is insufficient evidence for the use of chloroquine or hydroxychloroquine. These are both anti-malarial agents that have demonstrated antiviral effects on the COVID in vitro. Prior studies have found inhibitory effects of chloroquine for multiple RNA viruses in vitro, but randomized controlled trials and treatment of other viruses such as dengue infections and of influenza prophylaxis have failed to demonstrate antiviral or actual in vivo clinical benefits. A recent consensus document recommended chloroquine phosphate 500 milligrams twice daily for a minimum of 5 days, with dose modifications if severe GI side effects occur. Since chloroquine is not available in some countries, hydroxychloroquine is an alternative. A recent study in China explored various dosing regimens of chloroquine and hydroxychloroquine using physiologically based pharmacokinetic models. The study found hydrochloroquine to be more potent than chloroquine in inhibiting inhibiting the COVID virus in vitro. Based on these models, a hydroxychloroquine loading dose of 400 milligrams twice daily followed by 200 milligrams twice daily for 4 days was recommended. A recent systematic review found no published studies in COVID-19 patients. Pending the results of ongoing trials, the panel was unable to issue a recommendation for or against chloroquine at this time. They're also saying there's insufficient evidence to issue a recommendation of the use of tocilizumab in critically ill adults with COVID. This is a humanized immunoglobulin that functions to block the immune response and block IL-6 from binding to the IL-6 receptor. It has been approved in previous inflammatory conditions, and again, they're hoping that it may help fight the immune response that eventually leads to the ARDS in these COVID positive patients. Thank you. I'd happy to answer any questions via email. And again, this entire document is available on the SCCM website. Thank you. Thanks again.